This footage shows exactly what an intramuscular injection is designed to do. Drive a needle past the skin and the yellow layer of subcutaneous fat, so it halts inside the dense, red tissue of the muscle itself. If you failed to reach that deep tissue, the medication pool sits in the fat layer, leading to poor absorption. But if you hit the wrong underlying structure, you risk severe nerve damage. To prevent both of those failures, we are going to map out the correct anatomical injection site based on your specific medication, and then lock in the exact angle of entry. Before you begin, confirm your variables. You must know your patient's age, the total volume of your dose, and you should have an uncapped syringe prepared and ready. An intramuscular injection is a calculated delivery. It requires absolute anatomical precision. This diagram maps 4 injection zones: the upper arm, outer thigh, side hip, and upper outer buttock. We filter these options by patient age and dose volume. For a standard vaccine or small adult dose, the flowchart isolates the upper arm. The clinical term for this target is the deltoid muscle. To find the injection point, physically inspect the upper arm and locate the thickest, most central belly of the muscle tissue. The deltoid is a relatively small muscle group. Forcing a large volume dose into this space will cause significant tissue stretching and pain. Because of its easy access, the deltoid serves as your default tactical choice for routine, low-volume strikes that require rapid, localized delivery. When the upper arm is anatomically insufficient, we shift our focus down to the legs. This pathway applies if your patient is an infant whose arm muscles have not yet developed enough mass, or if you are treating an adult requiring rapid emergency access through clothing. This split-screen model highlights our specific target for these scenarios on both infants and adults, the vastus lateralis. You can locate this muscular band by tracing the area strictly along the outside face of the thigh. The vastus lateralis provides immediate accessibility and lacks major underlying nerves or blood vessels. This makes it the prime reservoir for both emergency and pediatric medicine. Now we look at the final scenario, the need to safely deliver a large volume of liquid medication. This diagram outlines the target zone, anatomically engineered for bulk delivery, the ventrogluteal area. To map this site, position your hand over the side of the patient's hip. You must keep the target explicitly on the lateral side of the body, distinct from the rear posterior. The advantage of the ventrogluteal site is its deep muscle thickness, combined with a complete lack of major nerves and blood vessels. That deep tissue acts as an anatomical vault, absorbing large volumes of liquid without complication, and making the side hip your ultimate safety zone. For decades, medical training pointed to a different location for large injections, the upper outer buttock. Clinically, this area is known as the dorsogluteal site. This visual highlights the severe structural hazard hidden directly beneath that muscle tissue, the sciatic nerve. A slight miscalculation in your needle placement here can strike the nerve, resulting in permanent damage or even lower body paralysis. Unless you are explicitly commanded by a physician to use this site, you must actively rule it out and avoid the area entirely. Relying on outdated anatomical assumptions introduces unnecessary risk. Modern protocol demands avoiding the hazard zone. Step 1 is knowing exactly where to strike. Step 2 brings the focus out of the anatomical map and onto the physical syringe in your hand. This specific video demonstrates the final, absolute mandate of the modern intramuscular protocol, establishing an exact, rigid 90-degree alignment before you strike. This cross-section compares the strict 90-degree drop against a slanted 45-degree subcutaneous approach. Because of the angle, the slanted needle fails to clear the fat layer, while the vertical drop hits deep muscle perfectly. To achieve this, physically lock your wrist. Position the needle so it is pointing dead straight down at your selected site. A perfectly selected anatomical site fails if your trajectory is flawed. Maintaining geometric discipline guarantees target acquisition. Let's review the steps. You have checked your variables, isolated the specific muscle, and locked your needle angle. By completing this checklist, you have systematically eliminated the guesswork and anatomical risks from the procedure. You now have your final clearance. Clean your chosen site and confidently administer the fluid directly into the muscle. Applied anatomical knowledge turns